start.
Good evening, friends. Welcome to Major Big Oncology classes. Today we will be discussing regarding the elective pelvic nodal irradiation. There are so many tumors in which we see that as well as we treat the primary tumor, the pelvic lymph node is highly required to be treated unless until the indication is not there, like the carcinoma cervix, CA endometrium, CA rectum, CA anal canal, CA urinary bladder, CA prostate. We usually require a pelvic lymph node irradiation. So regarding the pelvic lymph node, we start the pelvic lymph node, lower para-aortic lymph nodes, and then along with the bifurcation of aorta, these lymph nodes lie on the vicinity of vessels. So at the level of L4, here you see the right and left common iliac artery divide at the level of L4 vertebra, and then right common iliac nodes, left common iliac lymph nodes, and the presacral lymph nodes in front of a S1 S2 vertebra, and then the right common iliac artery divides into the right external iliac artery, right internal iliac artery, and similarly the opposite side. So that right external iliac lymph node, right internal iliac lymph nodes, and in between the external and internal iliac lymph nodes you find the obturator lymph nodes, hypogastric lymph nodes, and then presacral lymph nodes. I've already told you. So if you see here, you see that it's a in the upper cut of a CT pelvis slice, and you see here the aorta, inferior vena cava, and then either side these lymph nodes lie in the vicinity of aorta, right para-aortic and left para-aortic lymph nodes, and then along with the external iliac vessels, you see external iliac lymph node, and then internal iliac lymph nodes, and in between you see the obturator lymph nodes in between the external and internal iliac lymph nodes, and in the you see the common iliac lymph nodes right. The aorta divides at the L4 level, right and left common iliac artery, and then the right common iliac lymph node and left common iliac lymph nodes. These lymph nodes are required to be treated along with the primary tumor. So how we do it? You see here, this is aorta. Aorta divides. You see here that the L4 vertebra, and then right common iliac and left common iliac artery, and along with the aorta you see inferior vena cava. So how we contour the lymph node? So right common iliac and left common iliac along with the three sacral lymph nodes in the sacral vertebra, S1 in front of S1 S2 vertebra. You see here be little cautious that the bowel should not be involved, and the bowel loop should not be coming in the portal. If it is there, then you must. Now you see here you see the sacroiliac joint. So that I told you the landmark, bony landmark L4 vertebra, the division of right and left common iliac artery, and then the right common iliac artery divides into the external iliac and internal iliac at the level of a sacroiliac joint. This is the bowel, so you have to protect it. So you try to avoid bowel as much as you can, but you have to treat the pre-sacral group of lymph nodes along with the common iliac vessels. So this common iliac is getting divided into external and internal iliac vessels, and the lymph node lies along this. So how do you confirm that you have contoured the presacral and the lymph node? You see the sacral vertebra, this L5 vertebra, and the sagittal view you see the S1 and S2. So the lower border of S2 is the ending point of presacral vertebra, presacral lymph nodes. So I think one or two more slices be required. And this area you can trim off, because presacral area is usually taken a 1 centimeter, and the system which this system is not allowing to depict the distance, so that otherwise you can mark this area the 1 centimeter in front of a prevertebral space. So you see here almost we have reached here. Now at the lower border of S2 you start contouring external and anterior iliac lymph nodes. So you can see here the external iliac vessel, internal iliac vessels, and the external iliac vessels is to be taken up to the level of head of the femur. So you see the external iliac and the internal iliac vessels. Unnecessarily don't go towards the obturator internus muscle on this pelvic side wall, which is not unnecessarily taking an extra volume. The extra part. You can see the bowel loops here, and these bowel loops. See external iliac vessels, and we have to go up to the head of the femur. So the 2-3 landmarks we should remember: the lower border of S2 vertebra, the sacral vertebra, L4 vertebra, the head of the femur, and then the pubic symphysis top edge. So these bony landmarks help you to properly delineate the pelvic lymph nodes. It has been seen by the Taylor et al. In the extensive research. There's the lymph node lies in the vicinity of 7 millimeter distance from these pelvic vessels. So we, after giving contouring along the vessels, we give a 7 millimeter margin to encompass the lymph node, which we must remember, and we can go through that article of a landmark article by the female radiation oncologist Taylor. Now we are getting the head of the femur. So when we see the lymph node is involved, lymph node is not a rounded structure, it's a oval structure. So there are long axis and the short axis. So when the lymph node is enlarged, when is said to be enlarged or studded with the meds, then what we see, we say that you measure the short axis diameter. If it is short axis diameter is more than 1 centimeter, then it is significant. That means that the lymph node is involved, and in oncology that it prompts you to treat that very lymph node unless the elective nodal irradiation is warranted. In case of a prostate tumor, that elective nodal irradiation is not indicated unless we go for a scoring system with the help of PSA score and as well as the Gleason score, and then with the Rose formula we calculate the risk. If it is high risk, then elective nodal irradiation is indicated. So we are approaching towards the head of the femur. Why we are strengthening upon the head of the femur level, I will tell you. So the external internal iliac vessels we have picked up. So from the head of the humerus you see external iliac. Beyond that, the external iliac vessels become a femoral vessels. You can see here this vessel is atherosclerosed, calcified. You can see the but I think we should take one more slice. It's better take one more slice and make sure that you can trim off this system. You can see the uterus, the bowel loops, and then the uterus you start seeing here, the fallopian tube, this fallopian tube, and beyond that the adnexa, the sigmoid colon, rectum. So what I was telling you that this is the end of the external and internal iliac vessels. So beyond now this, after that slice, you take obturator group of lymph nodes and internal iliac group of lymph nodes. And be cautious not to take unnecessary obturator internus muscle, which is lying close vicinity obturator group of lymph nodes. The surgeon says it is the most difficult group of lymph node while doing the pelvic lymph node dissections. I mean, I am not a surgeon, but the people says that the surgical oncologists are facing sometimes a difficulty in removing these obturator group of lymph nodes. And then that is the beauty of a radiation oncologist, that you can treat the obturator group of lymph nodes. So what I am covering is obturator group of lymph nodes, and a few of the internal iliac lymph nodes. You can see the obturator foramen. Beyond that, you start seeing the obturator foramen here. This obturator foramen you can see, and you have to go up to the top of the pubic symphysis. We need not to go to this area because this is obturator internus muscle, so we need not to go inside that. You can see here the most dependent part of the urinary bladder and the dye here. So what I'll tell you, it's the rectum here, and then you start seeing the flat structure. This is the vagina, and then this flat structure, when it becomes rounded in shape, it's a cervix. I mean, you can this cervix, and then uterus, and then the fallopian tube. So thus, once you see the fallopian tube, and then below that is the adnexa and the parametrium, which you require to treat in the carcinoma cervix. You can see here the fallopian tube. So you can see in the sagittal section as well. So let us focus on this pelvic lymph node mapping, which we reached here up to, but we will have to go up to the, this is a paravaginal space, and in the cervix, when you go and the rounded structure, you see the paracervical space. The paracervical space need to be treated because more than 75% cases the pelvic paracervical group of lymph nodes involved in the carcinoma cervix, even in the early stage as well. So this is the top of pubic symphysis. So we have reached to the top of our pubic symphysis, our final destination of the pelvic lymph node. So if we see here, and then after that we can give 7 millimeter margin along with these islands of a contour, and then click the button on the finish. You will see here the uterus which we contour, uterus, cervix. Sometimes the disease is spread to the uterosacral ligament, which is very difficult. Then in this region, that when the disease involves the uterosacral ligament, then it is almost impossible to save the rectum actually. Sometimes because we have to treat the uterosacral ligament is coming from here to this side, from utero to sacrum, and in between the rectum is there. So with this we can see to show you to the different cancer, that's prostate cancer, in which we almost the pelvic lymph node contouring is a similar process. Either it is a prostate cancer, cervical cancer, or rectal cancer. Some sort of some little bit changes is there in the rectal cancer, because we have to take the mesorectal fascia. So here you see here in the prostate cancer, the prostate and the seminal vesicle, and then the side. This is obturator group of lymph node, seminal vesicle. In the high risk cases, you almost in the most of the cases you have to include the seminal vesicle in the prostate cancer. You can see here the pelvic lymph nodes is mapped out here nicely. On this side, on the behind the prostate, you see the seminal vesicle. So, and the presacral lymph nodes, common iliac and presacral. So with this, I think we end up with this thing, and try to learn how to map out the pelvic lymph nodes, and then contour it, and then give 7 millimeter margin, and then some internal margin and a setup margin to create a PTV along with the primary tumor. So with this we end this video, and we'll be meeting in the second video with a different organ of contouring. Thank you very much.